Hello, everyone, and welcome to this talk on osteoporosis. My name is Farhan. I'm one of the IMT3 trainees. I will be using a lot of information from the NOGG guidelines. That's the National Osteoporosis Guideline Group, guidelines from 2017. These guidelines are due to be updated next year, so a lot of what I have put on this slideshow is taken from other resources and as up-to-date information as possible. I'll be linking all the relevant articles in the description section below. So some learning objectives for the talk. First of all, appreciate the burden of osteoporosis, then understand when and how to investigate osteoporosis, apply underlying pathophysiology to management and prevention of osteoporosis, and be aware of new directions for some osteoporosis research. So first of all, a lot of you will be aware of the significant burden that osteoporosis carries and how common it is in the community. 1 in 2 women above the age of 50 and 1 in 5 men above the age of 50 suffer from osteoporosis-related fractures, which is just so significant. And certainly there's been a lot of work in the recent years to improve understanding and treatment and management, and indeed screening for osteoporosis in the community. I certainly had to do a lot of education going into this talk, because I don't think this necessarily translates as well into hospital education around osteoporosis. And that was part of the reason why I wanted to do this talk, because it had come up in conversation quite a lot, and I didn't quite have the most up-to-date information on osteoporosis. And I think a lot of the treatment and follow-up can indeed be started in hospital, and patient admissions with complications of osteoporosis can be the critical point for a lot of these management options. So staggeringly, in the first 3 months after a fractured neck of femur, there's an 8 times increased mortality. And this persists up until the end of the first year, albeit slightly diminished, but there is an increased mortality for the first 12 months after a fracture. Fractures from osteoporosis, otherwise known as frailty fractures, so those sustained from standing height, cost the NHS £4.4 billion a year, which is also a significant burden. So going back to sort of the basic underlying principles, what factors contribute to bone strength itself? Well, osteoporosis has numerous definitions, but the one that that's perhaps most clinically relevant is an abnormality of bone homeostasis, which results in reduced bone mineral density. And we'll come back to bone mineral density later on, but just going back to sort of the core concept of bone strength, it's kind of governed by 2 things: peak bone mass and an imbalance in bone homeostasis or bone remodeling. Peak bone mass is somewhat it's both as a result of genetic determinants, so non-modifiable risk factors, and also modifiable environmental factors such as nutrition, exercise, smoking, estrogen levels, actually I should say sort of estrogen exposure throughout a lifespan. And interestingly also, there's a significant amount of work that's shown that intrauterine life, so maternal nutrition, whether the mother smokes, and levels of maternal exercise can contribute to someone's peak bone mass. A lot of these things are still being looked into, and certainly whether there's any sort of a genetic basis for screening is something that is I'll allude to later on in the talk. But really, I'd like to focus on this imbalance in bone remodeling as a scientific concept. I'll go into it in a bit more detail. So bone homeostasis is a balance between bone formation, bone resorption. Whenever our bones suffer any degree of microtrauma, our osteoblasts and osteoclasts work sort of together in tandem, but also signaling to each other to, first of all, go in and resorb bone. So that's the osteoclasts. They'll go in and shred away any of the area of damage around an inflamed microtrauma. And then osteoblasts will get signaled to come on in and increase the level of bone there and successfully remodel the bone. However, during osteoporosis, there's an imbalance in this process, and there's a higher degree of bone resorption when compared to bone formation. And this is, especially in the last few years, it's been shown to be a inflammatory condition predominantly. And so there are a lot of pro-inflammatory sort of cytokines and other signaling molecules, and indeed a lot of pro-inflammatory cells that contribute from all lineages. But an important pathway is the rank pathway, NF-kappa B, you might have heard of, which is quite a significant signaling pathway in a lot of different inflammatory processes throughout the body, but features here in a really significant way. And the rank pathway is activated by this rank receptor on the surface of osteoclasts. And rank ligand is secreted by osteoblasts to signal osteoclasts to come in and start resorbing bone. And that will, the relevance of rank ligand will become clear later on. So now that we understand a bit about this imbalance that leads to osteoporosis, when does it really kick in, and in whom is it relevant to investigate for osteoporosis? So actually in the NOGG guidelines that I mentioned earlier on, there at the time in 2017, it wasn't quite clear whether screening for osteoporosis would have been beneficial, but there's been quite a few important trials, the largest of which is the SCOOP trial in the Lancet, published in 2018, which showed that actually screening did particularly reduce the incidence of hip fractures in the postmenopausal age group particularly. And so all women above the age of 65, equal to above the age of 65, all men equal above to the age of 75 should have screening for osteoporosis. And I'll go into how this should be done in a minute. Those between the ages of 50 and the aforementioned ages who have a particular susceptibility, so previous fragility fracture, falls, steroid use, anorexia, smoking, increased alcohol consumption, and secondary osteoporosis, so that from a underlying chronic condition, either an endocrine, rheumatological, hematological, or as a result of COPD or CKD. And those, a minority of patients who are younger than 50 who have frequent steroid use, possibly due to a chronic condition, and frequent is defined as 7.5 milligrams of prednisolone daily for greater than 3 months. So how do we actually initiate investigation and screening for these patient populations? Well, but actually before I go into that, it's important to exclude at this point, whenever you're thinking about a particular patient who's at risk of developing osteoporosis, or indeed has had a fragility fracture, could it be something else that's contributing to this, an underlying disease? Of note, there are 4 diseases that NICE sort of urge us to think about at this point: metastatic bone disease, multiple myeloma, osteomalacia, and Paget's disease. And this will largely read through history and examination and potentially blood tests, but at this point, it's relevant to think about these things. So as I was mentioning earlier, we use risk scores as a primary way to investigate and screen for osteoporosis. And previously, you may have heard of the FRAX score that had been used for a long time. And now QFracture is actually the one that's been preferred. I'm not going to go into too much detail with regards to the differences, but QFracture has a wider age group from 30 to 99. It has a much larger capture for the relevant comorbidities that we mentioned that might increase someone's risk of osteoporosis. So FRAX misses a lot of those. The benefit of FRAX is also that you can do a pre-DEXA scan and post-DEXA scan FRAX score, and that the relevance of that will become clear later. But NICE recommend that QFracture be used as a preferred method for assessing someone's risk of developing osteoporotic fractures. And this is how to interpret both of them. I've got it all up here in case you decide to use either of them. With QFracture, it'll give you a risk percentage of developing a fragility fracture over the next 10 years. If that risk is 10% or even close to 10%, then that gives you at least an intermediate risk. And if it's 10% greater, that's a higher risk. With the FRAX score, just to quickly mention, you'll get a risk chart, which will give you a red, orange, or green level of risk, and that will correlate directly to the level of risk. And your next steps, as appropriate, is essentially to order a DEXA scan or offer a DEXA scan. And if the risk is low at this point, then the patient should receive lifestyle advice and be followed up again in 5 years' time. Just want to mention what that lifestyle, I'll go on to mention what that lifestyle advice is in a minute, but before we do that, so the DEXA scan is a bone densitometry scan. Essentially, the patient lies with an X-ray scanner that, a specialized X-ray scanner that fires off 2 sets of X-rays, and with an added degree of accuracy because of those 2 sets of X-ray X-radiation, a T-score can be obtained. And what a T-score essentially is the level of reduced bone density, bone mineral density, according to the levels of standard deviation below the norm. So, for instance, if you were to have a T-score between -1 to -2.5, that means you are 1 to 2.5 standard deviations from the norm for your bone density. In our patients with the most reduced bone density and therefore the greatest degree of osteoporosis and the highest risk of developing fragility fractures, that is defined as a cutoff of a T-score less than -2.5, and that's really important to remember. These patients need pharmacological treatment as well as lifestyle advice. If it's between -2.5 and -1, so in the amber range, then that would be require a 2-yearly follow-up with lifestyle advice, unless, of course, the physician believes there's any particular reason why this patient may require a closer degree of monitoring, so a more frequent follow-up. And if it's in the green zone, then treat the patient as if they were in the low risk group, so with a 5-year follow-up. There's one caveat to all of this, and that is particularly relevant to us as hospital physicians, which is if a postmenopausal female with a spinal fracture comes in on X-ray, then we can start pharmacological therapy straight away without the need for DEXA scan. DEXA scan is still advised in the guidelines, and that's because it can establish a baseline, which can then be followed up, but it shouldn't prevent you from starting pharmacological therapy. So I alluded earlier that lifestyle advice is really important, and actually, regardless of what risk category your patient fits into, this is really important. So four main things to talk about. First of all is sort of a falls assessment and involving the MDT at this point, because exercise, strength and balance training have shown to largely improve someone's prognosis with osteoporosis. Diet. Within diet, of course, there's a healthy, balanced diet, but also calcium and vitamin D optimization, really important. So calcium, the recommended amount is 700 to 1200 milligrams daily. So that roughly equates to, say, 1 serving of milk, 1 serving of cheese or yogurt, and 1 serving of green vegetables. That might be an easier way for patients to grasp that. And vitamin D optimization. So this is sort of perhaps beyond the scope of this talk, but it's important to take a vitamin D level in patients in whom there's a risk of vitamin D deficiency, and replacement regimes as per the NICE guidance. Smoking cessation is really important, and alcohol consumption restriction to less than 3 units per day is very crucial. And I'll also have some advice, some websites where you can get leaflets for patient advice later on in this talk. In terms of pharmacological management, there's really 2 broad categories. A lot of you will be familiar with the anti-resorptive treatments. So bisphosphonates, they always cause a lot of trouble on drug charts because they're the commonest ones, alendronic acid, is given once a week. But there's also risedronate and zoledronate, which is given IV once yearly. And then denosumab. So I'll go into how denosumab works in a second, but that's an alternative anti-resorptive therapy. And then there's the anabolic, or the bone-forming therapies. And these are really for specialist use only, but it's interesting to be aware of what other possible sort of pharmacology and pharmacotherapy we have at our disposal. So there's teriparatide and romosozumab, which are subcut therapies, which can be used, but obviously after consulting a bone specialist. And I'll go into how those work as well, just for interest. It's really important that we optimize vitamin D. I've already mentioned it. In particular, before starting any of these IV or subcut therapies, vitamin D optimization is really crucial. So, bisphosphonates. We use them, we're quite comfortable with them, but what do they actually do? So they're called bisphosphonates because they have these 2 phosphorus-based groups, and they're really important because they bind with great affinity to hydroxyapatite, which is a major mineral within bones. And it has quite a high half-life as it is, 5 weeks. But then what happens is, as the bisphosphonates used and the bisphosphonate bound hydroxyapatite is reincorporated into bone, it can actually have a half-life up to 5 years, which is, which tells you a lot about why the dosing schedule is what it is. That's quite significant. Conversely, bisphosphonates also have a really low bioavailability orally. So you may have noticed pharmacists will come in and write in that patients need to be fasting for 30 minutes afterwards, or to have it 30 minutes before breakfast, and maintain an upright posture for 30 minutes. Those are the reasons why. In terms of the pharmacodynamics, so the way bisphosphonates work is that they inhibit FPPS, or farnesyl PP synthase, and interestingly, depending on what your definition of interesting is, they actually work on the same pathway as HMG-CoA reductase inhibitors, aka statins. But the end goal of bisphosphonates is to sort of inhibit the production of prenylated proteins and prevent the formation of osteoclasts, but both through osteoclast apoptosis, actually, and reduction in numbers, but also through they can disrupt the membrane of osteoclasts due to these the lack of these prenylated proteins. So, an important point is that they're released during bone resorption specifically. So although they bind with great affinity to bone, they then become released when there's an acidic environment. So during bone resorption. Interestingly, so I'm going to come on to the risks now. So interesting that they're released during an acidic environment, because that makes them particularly potent within the stomach, and they can cause or exacerbate stomach ulcers. So if a patient's had an ulcer in the last 1 year, or there's a history of upper GI bleeding or inflammation, then it's just something to be aware of under caution. So make sure that there's no sort of active disease, recent disease, or the patient is adequately counseled about the risks. And secondly, there's a lot of sort of awareness about osteonecrosis of the jaw. So this sort of rare condition that bisphosphonates can cause. It's particularly important if someone's got any susceptibility to dental infections, or has any dental work recently or upcoming, that we make them aware, or make their dentists aware, that they're going to be on bisphosphonates. But otherwise, just to be aware that they're particularly common with IV zoledronate, as opposed to their oral counterparts, just purely because the IV dose has, a lot more potency. So I mentioned bisphosphonates, and we know how they work. We've gone into detail, but denosumab works, as I mentioned earlier, the rank ligand, which binds to rank and prevents osteoclast activation. The rank ligand that binds to rank and results in osteoclast activation. Denosumab prevents that process by binding to and inhibiting rank ligand. So it's pretty simple. There's not much else to say really regarding that. It's a autoantibody directed at rank ligand. So we've gone over the medications that decrease osteoclast function, so the anti-resorptives. But what about the other half? So in terms of the bone forming agents, it's just interesting to think about how they work. So teriparatide, so just focusing on the left side of this slide for the time being, works by binding to, so teriparatide is actually a synthetic parathormone type molecule that has the active portion of parathyroid hormone, and it binds to parathyroid hormone receptors on osteoblasts and causes them to on immature osteoblasts or osteoblast precursors, and causes them to mature into active osteoblasts. And so I thought that was quite an interesting molecule. And this very complicated diagram on the right, I just want to draw your attention to the romosozumab in here. And all we really need to grasp is that there's this signaling pathway called the Wnt signaling pathway, and that results in increased differentiation from precursors into osteoblasts and decreased differentiation of those precursors into adipocytes. So it's really, again, promoting the osteoblast numbers and osteoblast function. There are also lots of other minor effects, but that's really the important one to know about. And how it does that is by binding to this inhibitor of the Wnt pathway known as sclerostin. What's important to just keep in mind is that these newer sort of more specialist therapies have a much higher effect, interestingly, on bone mineral density. Teriparatide, off the top of my head, has a trifold effect of bisphosphonates on bone mineral density, and romosozumab has a 5 times increased beneficial effect on bone mineral density than bisphosphonates. But It's a complicated question as to why we don't use them more often. Side effect profile is one thing, but wealth of evidence actually has become less of an issue, because there have been several large trials that have shown the benefit of these drugs. One particular concern that I read in a Nature article that I've linked there is that both of these drugs potentially both potentiate osteoblasts, but also the osteoblast-mediated osteoclast activity, so that rank and rank ligand effect. So they do, whilst they do have an initial period of bone building and bone formation, it then creates an increased effect of osteoclast activity due to that rank-mediated system, and then results in increased bone resorption, which sort of is what we're trying to counter in the first place. So the article talks about a reduction in the bone forming window because of an upregulated osteoclast activity, which I thought was quite interesting. So this is just a sort of like a summary slide in terms of the underlying pathophysiology of all the current anti-osteoporotic treatments available. And I know one of the learning objectives was looking into sort of future research and future directions for research. One thing to note is that we're learning more and more about bone homeostasis and the various things that affect it. And one thing that I thought that was really interesting was that those pathways we've talked about, so the Wnt signaling pathway and the parathyroid hormone related signaling pathway, that beneficial effect on bone formation, we don't actually even need medication to do that. Mechanotransduction or mechanical loading, or better known as exercise, actually influences our bone to trigger osteoblasts to form more bone. That positive anabolic effect that we're trying to encourage in our osteoporotic patients, we can actually do just by giving them reasonable exercise, by encouraging them in line with the MDT and as per the physiotherapists, but trying to get them moving. And that's nothing new. That's something that we do all the time on the wards. This busy slide is sort of just looking back at all the genome-wide associated studies into osteoporosis, and there's just been loads and loads of development in the last couple of decades. And these are all the studies if you're ever interested. And the way they've translated into our practice is that they have confirmed the benefit that we saw in the lab with regards to the various therapies that we have, and they've managed to confirm the specific genes that have or the specific protein targets that we've been using. They've managed to confirm have that particular connection to our genome. In terms of particular risk factors for osteoporosis, I thought this was quite an interesting diagram that they included. So the red boxes here are established risk factors for osteoporosis as per the genome-wide studies. So a causal link has been established. The black ones, there is an association, but not a causal link. And the blue boxes are, they remain sort of controversial even with the genome-wide studies. And something I read that was quite interesting was that osteoporosis is one of these very heterogeneous genomic sort of entities, in that it's largely the associations that we found have largely been with genes that are non-coding and sort of in between the coding genes, and they influence expression of other genes in sort of non-stereotypical ways, and that's what makes it particularly heterogeneous and particularly challenging to get these associations. This next slide is just another future direction that we're going into, in that osteoporosis has become more sort of an immunological phenomenon, and our understanding of it, as our understanding of it has evolved, immunoporosis has become sort of like a fashionable term in terms of studying the direction that osteoporosis is headed in. And actually, this slide just shows that there are so many immune cells involved in all of our known pathways towards osteoclast activation, osteoclast bone resorption. And actually, there's numerous different ways and numerous different roles that they have. So it's just, I've left these slides up there and the link for the paper if anyone's interested. Fascinating. So some take-home messages. As I mentioned, osteoporosis is increasingly common. We use QFracture score in the community. Our GP colleagues will be screening patients above the ages that I've mentioned earlier. So greater than 65 in women, greater than 75 in men, or greater than 50 in either gender with at-risk individuals. And I've talked a little bit about how to use the QFracture score. And if the QFracture score returns a risk of around 10% or greater, or actually slightly less than 10%, then that would warrant a consideration for DEXA scan. A DEXA scan is a densometry scan with X radiation, and it will basically give you a T-score. A T-score basically correlates to standard deviations below normal bone density, and our cutoffs for pharmacological treatment are a T-score of less than -2.5. An important caveat that we discussed was that patients who are postmenopausal women who have spine fractures on X-ray, they can be started on our bisphosphonate or denosumab therapy without waiting for DEXA scans. And we talked a bit about anti-resorptive and bone-forming therapies. We talked about the pathophysiology, and we've looked into sort of new directions for understanding and therapy for osteoporosis. So with that, I conclude my talk. Thank you very much. I'll have the link to all the studies in the description, and that's my email if anything I've mentioned needs re-looking at, or if someone has any sort of feedback, I'm happy to sort of adjust the slides or discuss things. Thank you very much. And here's the resources for patients that I mentioned earlier. So I'll just leave those up. And if you have a patient who needs further written information, then can always Google any of those. Thanks again.